Alterations in cognition and sensation, head and spinal cord trauma. A concussion is a blow to the head that jars the brain. We see temporary neurologic impairment. These clients may experience a brief lapse of consciousness, disorientation. They may have a headache or blurred or double vision. They may also have emotional irritability and dizziness. We diagnose with a skull radiography, CT scan, or MRI. We're going to manage it with temporary inactivity, mild analgesias, and observe for any neurological complications. Nurses should perform that neurological assessment and observe for signs of increased intracranial pressure. The client should be instructed when to contact the physician or return to the emergency department if symptoms of increased intracranial pressure occur. A contusion may be a coup or contra-coup injury with cerebral edema present. The coup is going to be a direct injury, where the contra-coup is where they have a direct injury and the brain bounces in the skull and receives an injury on the opposite side of the skull. These clients may experience hypotension, a rapid weak pulse, shallow respirations, pale clammy skin, temporary amnesia, and they may experience effects of permanent brain damage. We diagnose with a skull X-ray, CT scan, and MRI. Medically, we administer drug therapy or mechanical ventilation if there's respiratory compromise. Nurses should periodically monitor the level of consciousness, neurological changes, respiratory distress, and signs of increased intracranial pressure, along with vital signs. We should also teach head injury prevention by the wearing of seat belts, appropriate infant car seat use, use of protective headgear, neck restraints, or avoiding alcohol and drugs while driving. True or false? A contusion assessment findings will include hypertension, a rapid weak pulse, shallow respirations, and pale clammy skin. This is false. True or false? A concussion is a blow to the head that jars the brain. This is true. So cerebral hematoma is obtained from a head injury, a cerebrovascular disorder, and there's three types. We have epidural, subdural, and intracerebral. The assessment is going to be dependent on where the location of the trauma is, the amount that the brain is bleeding, the hematoma size, and autoregulation. We may diagnose with an MRI, a CT scan, or ICP monitoring. We're going to treat it depending on the symptoms. So indications of a surgical emergency would include a rapid change in level of consciousness and signs of uncontrolled increased intracranial pressure. Surgical management would include burr holes or intracranial surgery with a craniotomy, craniectomy, or cranioplasty. And we could do a supratentorial or infratentorial surgical approach. Nurses should consider all head injuries to be emergencies. We need to obtain a good history, neurological examination, vital signs, and level of consciousness. Determine appropriate limb movement and pupil reactions. Excuse me. With trauma, we need to do a head examination and examine the respiratory status and obtain neurological or monitor for neurological changes. Preoperative nursing care may include hair removal, obtaining vital signs, neurological assessment, and application of anti-embolism stockings, in addition to restricting fluids. Postoperatively, the client should be kept supine or side-lying position. We should also monitor regularly for signs of increased intracranial pressure, and we need to control thrombus or embolus formation and cerebral edema. Skull fractures are from head injuries, and they can be open or closed. They can also be simple, depressed, or comminuted. These clients may experience localized headaches, bumps, bruises, or lacerations, hemiparesis or shock. They may have rhinorrhea or otorrhea, periorbital ecchymosis, also known as the battle sign or raccoon eyes. We may also see conjunctival hemorrhages or seizures. Diagnostically, we do skull radiographs, CT scan or MRI. Surgically, with a simple fracture, they're just going to require, and medically, just require bed rest or observation for increased intracranial pressure. A lacerated scalp would need to be cleaned, debrided, and sutured. A depressed skull fracture may require a craniotomy and antibiotics, along with osmotic diuretics and anticonvulsants. Nurses should monitor these signs of head trauma, look for drainage from the nose or ear, looking for that halo sign to see if it's cerebrospinal fluid or CSF. And neurologically, do hourly level of consciousness, pupil, motor, and sensory status checks, or every 15 to 30 minutes do the vital signs, and prepare for the possibility of seizures. Spinal cord injuries can be from accidents such as vehicular or violence. We may see spinal shock or areflexia. We may also see autonomic dysreflexia, where we have a hyper state. These clients may have pain or difficulty breathing, numbness, and paralysis, and they require significant neurological examinations. We diagnose with radiography, myelography, MRIs, and CT scans. Medically, they may require a cervical collar, cast or brace, traction, a turning frame. They may require IVs. We have to stabilize their vital signs, and we may be administering corticosteroids. Surgically, they may require bone fragment removal. We may need to repair dislocated vertebrae or provide some type of spine stabilization. These clients often are going to be in some type of a traction or brace. In spinal nerve root compression comes from some type of trauma or herniated intravertebral discs or tumors of the spinal cord. These clients may experience weakness, paralysis, pain, or paresthesias. We diagnose with spinal x-rays, CT scans, MRIs, myelography, or electromyography. These clients will also probably be wearing a cervical collar or some type of brace. They may require bed rest, skin traction, and hot moist packs. Skeletal muscle relaxants may be administered in addition to other drug therapy such as corticosteroids and analgesics. Surgically, we may do a discectomy, a laminectomy, or a spinal fusion. Nurses should do neurological examinations to make sure there's no deficits. Conservatively, we need to support that spine and alignment. Any type of spinal injury, we need to be doing log rolling, supporting the head. These clients may be required to have bed rest in a semi-Fowler's position or traction. And we should also teach appropriate body mechanics. We may administer muscle relaxants and analgesics and apply moist heat and evaluate their response to therapy. Post-operative, we need to monitor vital signs, do those deep breathing exercises, examine the dressings for cerebrospinal fluid leakage or bleeding, assess their neurovascular status. We need to make sure they're voiding or defecating appropriately, and these clients will be using fracture bedpans for a while. So post-operatively, how often should deep breathing exercises be done for a client that has had surgery for spinal cord injury? Hourly.